I started thinking about it, and I thought maybe it'd be a little more useful if I gave sort of an overview of sort of the application of some different image analysis procedures to some health-related problems, and then sort of tied that into the kind of measurements that I make, and then finally show some of the capabilities of this Image Pro software that I use. So I'm going to kind of do things in reverse order. I'm going to show the applications first and then explain how I got to that point afterwards. And we'll just kind of see how the time goes. I don't really know how long this whole thing is going to take because I sort of took pieces of an image processing seminar that I used to present to different companies and spliced that in. But I think the most important part for medical researchers is the medical applications. And I think you'll see that image processing is used in all sorts of different applications now. And I just listed some of the first ones here. These are what you maybe would normally think of in the clinic, image processing of these non-invasive types of imaging techniques like MRI, PET, CT, and even ultrasound. But I'm not going to talk about any of those today. I'm going to talk exclusively about immunohistochemistry. So everything, and you'll see in the literature all the time, you'll see vessel counts or different staining techniques, and they use image analysis techniques to try and quantify them. And probably about 90% of what you read in literature is done incorrectly, it seems to me, in terms of how they're counting different things. So I'll kind of talk about some of the different problems as I go along and what I think are better ways to do the same types of measurements. And I'm going to concentrate mostly on hypoxia measurements and vessel counting kind of measurements. So first of all, I just wanted to put this out here so we have some idea why you might want to do image processing in the first place. I think most of these are pretty obvious. The first one, this one's used, most people use Photoshop for this kind of an application. They'll take their immunohistochemical pictures, which might be pretty lame looking to start with, and they'll pretty them up with Photoshop software. So you can pretty much take any kind of image and make anything you want out of it these days. So that's image processing, but it's not really what we're interested in. And what I'm going to talk mostly about is using the image processing techniques to improve your precision or accuracy of the measurements in the first place. So I mean, clearly a lot of the things that I'm measuring you could do by hand. You could look through the microscope and count microvessels, or measure positive staining with some arbitrary qualitative index like 4 pluses or 3 pluses, depending on how strong the staining is. But you can improve that if you have these quantitative techniques. You can improve the precision, the accuracy. Hopefully you can increase reproducibility if you set up your parameters right with your image processing. So if you do it the next day, you'll get the same answer, which may or may not be true with manual counts. Might have a lot of variability from person to person. And then finally, with these automated methods, you can get a lot higher throughput than what you could do with manual methods. So if you're counting vessels, for instance, you might do about 3 microscope fields and count the number of vessels. With these automated procedures, you can count thousands of vessels in seconds. So again, this is just one of my slides that I stole from another presentation, but it's kind of highlighting why you might want to use image processing instead of relying on your eyes. And the reasons are sort of fourfold here. The eyes are good as contrast, which means they can adjust to dark and light conditions automatically, sort of like an auto gain camera. But they're not really that great at distinguishing subtle variations in color, subtle variations in gray level, for instance, or even colors. And actually, the eye can only detect about 30 different continuous levels of gray, and I'll show you some sort of examples of that. And if you're looking at distance or intensity measurements, especially of objects that are adjacent to each other, the eyes aren't very good judges of either one, and the eyes aren't that reproducible for repeated measures. So this is one, you've probably seen this 1,000 times, but it's that old optical illusion that shows you, these lines are both the same length, but if the eye looks at them, they'll think, that this line's longer. And then again with this, it looks like this is a lighter color than this gray when obviously they're the same one. So the eye is tricked by what's in adjacent areas. Now this is another one here. So what this shows is sort of the ability of the eye to detect different gray levels. And what this is on the left, this is just what this looks like to your eye is that I've just taken 8 equally spaced gray levels, right? And these ones look like they're uneven gradations. So this one here actually is the one that's equal variations from stripe to stripe. And the reason they don't look that way, what the eye actually sees is that it compresses the dark region. So these ones, your eye is much less sensitive to the dark variations than the light. So again, what this means, if you're looking at real dark regions and trying to distinguish things, it's going to be a lot better over in the bright regions. So this is what the machine is actually seeing when you're doing the image processing. This is what your eye is seeing. So you can see clearly it's improving in this region. But we're not going to be looking at 8 levels of gray when we're doing our image processing in the first place. We're going to be looking at about 4,000 levels of gray. So clearly the eye is not able to detect anywhere near the type of accuracy that we need. So in terms of vessel counting, this is probably the first thing that people started to do automatically in some of the immunohistochemical studies that you see in the literature. And the way it was originally done was they took breast tumor biopsies and they looked at just manually counting the number of vessels in the biopsies. And they found there was a relationship between the response of the patient or the survival of the patient and these vascular counts. And it was only later that they started using automated methods to do the same thing. So if you compare the two, in terms of manual, the way they did it, they either just looked at the number of vessels in the field or they looked at the areas of the highest vascular density and just counted those. And this is called hotspot vascular density. And it was found actually that these hotspot densities were better prognostic indicators than just the overall mean vessel counts. But again, both of these were done manually, and they just counted all the vessels they could see. A little later, actually not, it's been quite a while, they've been using this chocolate sampling also. And this is a manual. I guess I should show you what this is. This is just the vessels in the first place here. If you just look at an immunohistochemical stain, this is staining for the blood vessels, endothelial cells. So the old way was just to count them. And you can see it's pretty difficult to decide exactly how many vessels there are, you know, if it's a continuous vessel or different vessels. And this is going to be a problem you have with automated techniques also. So when they were doing it manually years ago, they came up with what were called chocolate sampling techniques. And for this, they just put the eyepiece reticle that had these random lengths, and they measured the number of intersections between the vessels and these lines to get an estimate of the vascular density. So this didn't really rely on whether it was single vessels or not, just on the total number of vessels in your field there. So the big problem with these kind of techniques is, first of all, they're laborious, and again, you can only do a limited sampling of the tumor to come up with your count, just because you wouldn't have time to count very many different ones. So with automated techniques, and you'll see all sorts of automated techniques using different image processing software in the literature, the big problem that most of them have is that to detect these vessels in the first place, you have to come up with some method of thresholding what's an object and what isn't an object. So it can be either auto detection techniques or you can set some manual threshold. And if your immunohistochemical slides aren't all done at the same time and processed the same way, this threshold is going to determine how many vessels you're actually going to find. And I'll sort of illustrate with some of the Image Pro techniques how dependent these counts are on this thresholding. So again, another way people do it automatically is that instead of trying to count the vessels in the first place, they'll just measure the percent area of vessels. And again, it's easy to do with image processing software. That area percent, again, is going to be totally dependent on where you set your threshold for what it calls a vessel. Now, the way we do it, and I'm going to go into this pretty laboriously, is what we call a distance analysis. So this relies on how far vessels are. It's kind of like the chocolate count, but it's been automated. So what we do, basically, we take frozen sections, we put them onto the microscope, and this little square here would be representative of what we'd see in just one microscope field. So the stage is automated, it moves along, and it combines about 16 fields into one huge montage here. And then we take the slide off and on, and we come up with multiple staining conditions. So first of all, we're just staining for where the blood vessels are here, and then over here we're staining for a hypoxia marker. So this is something I talked about back last year when I was doing the radiobiology talks. and it's used in patients and in animal studies. But essentially what you do with the hypoxia marker is you inject this, what's called EF5, which is a nitroimidazole. It's injected IV into the mouse. It diffuses out of the vessels, and it binds irreversibly with the hypoxic cells. So you can take a frozen section, use an antibody to the EF5, and you can get this fluorescent picture of where the hypoxic cells were in the tumor. So here you can see we did the same section just under fluorescent conditions here and normal light microscopy over here. And at the same time, we inject a perfusion marker into the mouse, and this goes into the vessels, and it highlights all the vessels that are open at a given instant. So you can see it's the same vessels. These are the ones that were open compared to total vessels here. And then you can overlay the hypoxia and see that. So you can see these things aren't actually like individual longitudinal sections of vessels. These are more like huge sinusoidal vessels. So if you're going to try and count this manually, it's pretty difficult. And again, so what we want to do is come up with some kind of quantitative index for how many vessels we have in here and the relationship between the vessels and the hypoxia, and how this changes with different treatments that we administer. So here you can see we administered anti-angiogenic drug endostatin to this tumor. And again, you can see it's creating more hypoxia in some regions. So we want to quantitate both the distribution of the hypoxia and changes in vessel number. If we're blocking vessel growth, we want to be able to quantitate that. So again, this is the same type of tumor, a mammary tumor. This is another mammary tumor, not much hypoxia in this one. Vessels all over, and it looks like most of them are perfused. So you can see there's huge differences between the tumors. If you're trying to quantitate this manually, it'd be a huge headache. So the first thing we did was try to determine the spacing of the blood vessels. And again, we start with endothelial staining here. And the first step is to actually threshold, and I'm not going to talk about how I thresholded it yet, but basically you set an intensity level or a color so that it forms a binary image, a black and white image of where the vessels are. So you take this, which is called a image mask, and then you do what's called a distance filter on it. And again, this is an image processing step which converts that last image to an image where the intensities are directly proportional to how far away each pixel is from the vessel. So you can see the blackest regions in this image are where all the vessels are located, and the whitest, that's where you're furthest away. So this is a gray level image. It gets brighter and brighter with each pixel you get away from the vessels. So this gives you a way to map the location of different stains in relation to the vessel stain. So we take the sampling grid just so we don't have to look at, you know, the millions of pixels that we have. We kind of take a subset of those by multiplying that distance map by a sampling grid like this. And then we pseudo-color it just so we can see it visually, more for this presentation than for anything. But this gives you an idea of where the vessels are, and the intensity is directly proportional to the spacing of the vessel, essentially. So we can take, so you can see there's a relationship between the vessels and this intensity map thing here. So this gives you the entire distribution of distances from any point in the tumor to the closest vessel. And you can plot that whole thing up and look at distributions, or you can, if you're publishing it, you probably just care about something like the mean vessel spacing. So this is sort of like a vascular density measurement. And you can see how these kind of measurements change with different types of treatments. Here we're comparing total vessels and perfused vessels and showing how the spacing changes with the radiation or these anti-angiogenic drugs. So the second thing we wanted to measure in these particular types of images was the overall hypoxia. And in the past, the more common way to do this, this is our main competitor in the Netherlands, Bert van der Kogel's work, and they've been doing this other hypoxia marker for years. And instead of EF5, this one's called pimonidazole. And they actually use a totally different method of quantitating than we do. And essentially, so here you can see, here they're using HIF1, which is a hypoxia-inducible factor, which is like an endogenous indicator of hypoxia. And then the pimonidazole is the one that they inject that binds to the hypoxic cells. So you can see their images aren't fluorescent, they're just light microscopy. And the dark brown staining is what corresponds to the hypoxia here. So what they do is they define an arbitrary threshold. So instead of looking at the intensity of hypoxia, they try and look at the area of hypoxia. So you can see if you threshold this on the brown and try and come up with an image mask, it's totally arbitrary what level you're going to use for this threshold. But that's the way they've been doing it for years. It's a lot easier, but you come up with images that look like this. We have sort of a pseudo color to look at where the hypoxia is. And here you can see the pulmonitazole is the green areas, and they're doing it in relation to the vessels. But by the time they're done, they basically just come up with a binary mask. So the green, they throw out all the intensity information and just give you a final measurement of percent hypoxia in the tumor. So that works okay if you set an arbitrary threshold, but it's hard to control all your different sections so that they're stained reproducibly. You have to have the same exposure to the antibodies, and everything has to be processed pretty much at the same time so that a constant threshold is going to work on these. So it's maybe not the best way to do it. Now with ours, again, we're starting with the EF5, a fluorescent image like this, and the simplest way to do it is just to look at the mean hypoxia. If you just want to know if there's huge gross differences in hypoxia between different treatment groups, you can just measure the overall intensity. And this is the kind of thing you get. So you can detect gross changes in hypoxia. Now whether this is particularly useful in trying to define the mechanisms for different drug combinations is probably debatable. And in some respects, this is comparable to this percent area measurement that they use with the pulmonitazole, except that it doesn't rely on having to set a threshold. But it does mean you have to process all your slides at the same time, and you have to make sure your light in your microscope is the same intensity. So you couldn't compare slides from one year with a previous year, that sort of a thing, because the variations would be too great between the specimens. So another way we looked at is to actually try and look at the distribution of hypoxia in relation to blood vessels. And this kind of highlights some of the disadvantages of the overall measurements in the first place. And one of the big ones is that if you look at the relationship between vessels and the hypoxia here, you see that it gets more hypoxic as you get further from the vessels, but it kind of peaks and then it starts getting darker again. And this is because of the fact that these cells are becoming necrotic, which again aren't going to take up the EF5. So if you looked at the overall EF5 intensity across this image, it would be, you'd have some artifacts just because of the necrosis here. So what we're going to do instead is going to look at the distribution, how the intensity varies as a distance from the blood vessels. And this gives you information in terms of both heterogeneities in the distribution and changes in oxygen consumption rate. Because if you have higher oxygen consumption rate, it's going to get brighter more quickly as you get further and further from the blood vessels. So the way we do this, and again I'm going to go through the image processing without really dwelling on the details till later. So again, we start with a superimposed image of the blood vessels and the hypoxia, and we take the original blood vessels, we make a mask of those, and we do this distance filter thing again. So again, this gives us a mask of intensities proportional to the distance from the blood vessel. So we can take this distance filter and we can actually threshold it. So it lets us selectively define specific regions in the image as a function of how far from the blood vessel they are. If I'm going too fast on any of these things, go ahead and stop me.
So a question about the thresholding, doesn't that process also depend on the gradations of the grayness or the gradations of the color? Like, don't you have to
right here? On this one, the thresholding, I'm going to see on this one, the way this distance map's defined is the intensity is 0 right at the vessel. And then every pixel you go out, it goes up 1 intensity level. So if you're out 10 pixels from the vessel, the intensity of this thing is going to be intensity 10, right? So if I threshold it and take all the intensities from, say, 0 to 10, that would be this white zone right here.
Okay, maybe I guess I was meaning back on one or two slides where you went from the original image to the white area.
Oh, back like here, going from here to here. Now, what was your question in terms of thresholding there?
Back to the previous slide, so doesn't that depend on
The brightness?
Yeah, the brightness.
Yeah, and some, this is probably the most critical part of the whole process is this thresholding step. And it's going to, there's automated detection algorithms that are written into these image processing packages like Image Pro. So if it's a real good stain like this, it'll do a great job of just recognizing those automatically based on the peak intensity versus the background intensity distributions. If it's a little bit more like that red one that I showed earlier, it's a lot more difficult. So I'll kind of get into those problems when I get into the image processing part.
We'll basically beta test, 100 images to make sure whatever algorithm he's picking gives us the truest visual thresholding, if you will. The computer's actually picking what we believe is positive staining and picking up enough of it.
And there's all sorts of different ways to threshold, and I'm going to talk about those little like different color models and intensity histograms and automated procedures, and you can kind of see how good a job it does on different types of slides once we get into the next part. So anyhow, this one, of course, this one isn't variable. This one we can just strictly use the thresholding to define specific zones. So I superimpose the vessels in here, and you can see if I threshold this thing between different limits, I can select like areas right around the vessels or a little bit further out or a little further out. So these white areas are what it calls sampling masks. So I can multiply these white areas times other slides to selectively filter out portions of the original image, and that's sort of shown here. So I take one of these masks, so this is maybe a mask looking at from 80 to 100 microns. This is just the region 80 to 100 microns.